A very good evening, everyone. Myself, G. Arunagiri from Government Medical College, Stuverrt, and I will be hosting this session today. I wholeheartedly welcome our AATRAL staff faculty, Dr. Rajapriya, ma'am. We can start the session, ma'am. Over to you, ma'am.
Okay, thank you.
I will share the PPT, ma'am.
Okay.
Is this visible?
So shall we start the presentation? Today we are going to mainly discuss Today we are mainly going to discuss about the obstetric case presentation. It's a last minute presentation, last minute preparation. So I've tried my best to do it. So you'll just vaguely look upon the vague case presentation. There's no particular details. So you'll see. We'll start with the name. What is the significance of name of the patient? Can you all unmute?
They can raise their hands, ma'am. I will unmute them.
Okay. It's not going to be an interactive session then.
If it's okay for you, I can unmute them.
Okay.
I will unmute them. Yeah. You all can unmute yourself.
Ma'am, we can find the religion based on the name.
Exactly. With the name, you can identify the person. That is most important. Identification of the patient is most important. Then with that, you can identify the race of the patient. With the race, you can identify the diseases involved in the race and the high risk factors along with the race. What is the significance of name in obstetrics? The race in obstetrics exactly. With the race, African race is more common as multiple pregnancy. And with Mongolian race, most common is abruptio placenta. What is most common in Indian race? It has nothing to do with race, but most common here is anemia. You can vaguely identify the following risk factors. What is the importance of age?
And teenage pregnancy.
Exactly. Either age. One is teenage pregnancy. Teenage pregnancy is associated with its own risk factors. What are the risk factors? Can you name some? We are just going to discuss the basic topics which are most commonly asked. These are the points which will for you to clear the exam. With the teenage pregnancy, most common is anemia, again abortions, hyperemesis. Patient can have IUGR, intrauterine fetal demise, and the patient can have operative vaginal deliveries or even cesarean section. Why there is a risk of operative vaginal deliveries or cesarean section?
Cephalopelvic disproportion.
Exactly. So what is the importance of elderly gravida? What is elderly gravida? A patient who is pregnant after 35 years of age. It is an elderly gravida. What are the risk factors in elderly gravida?
Congenital malformation of the fetus.
Exactly. Anomalies are most common. Multifetal pregnancies are most common. Then malpresentations are most common. Placenta previa, again anemia, again CPD, preterm labor, rupture uterus, PPH. These are all more common. Then what is the significance of residence? With the residence, you can identify the endemic diseases. Which is endemic in Chennai? One infectious disease which is always endemic in Chennai is dengue. So you can identify the endemic diseases. What is socioeconomic status? How will you classify? It is based on modified Kupuswami's classification. I hope you have studied this for other subjects, medicine, surgery. So socioeconomic status by modified Kupuswami's classification. What are the three factors we are studying here? We are looking at the educational qualification of the head of the family, the occupation of the head of the family, and the total family income. Based on this, you classify the patient has lower socioeconomic status, upper, middle, or even upper. How is it related to the patient? How is it related to us? What is most common? Yeah.
Certain diseases are common in low socioeconomic status, maybe anemia, multiple pregnancy, and there is a reduced birth,
Yes,
low spacing.
Yes, exactly. What is more common in upper? So upper class, obesity, hypertension, diabetes, elderly gravida, Again, all other risk factors. Then we are looking at the education status of the woman and husband. Education status helps in counseling the patient. How will you counsel the patient? It depends upon the education status. And occupation has its own occupation hazards. These all you know. Routine one. What is booked? What is a booked case? Antenatal mother who has visited a particular hospital for at least three visits, each in each trimester. Not 3 visits in first trimester, not 3 visits in second trimester. At least you must have one visit in each trimester. So we have divided our pregnancies into 3 trimesters. One is first trimester, which is still completed 14 weeks. Second trimester from 15 to 28 completed weeks. Then from then to 40 weeks is third trimester. Then we will discuss about the gestation age. I hope you can identify the gestation age importance. What is term?
More than 37 completed weeks.
Exactly. What is preterm?
Anything less than 37 weeks.
No, from 28 weeks to 37 weeks is preterm. This preterm can be classified as very early preterm, and late preterm. Anything beyond 35 is late preterm. From 32 is preterm. Then very early is 28 to 32. Next, we move on to the presenting complaints. What does the patient present with? We can say so and so, Mrs. X has come with complaints of intermittent lower abdominal pain for the past 1 or 2 hours. This will be the presenting complaints. Then you will include history of presenting illness. In the history of presenting illness, you will add all the negative histories. So she has no history of leaking pervaginum, no history of bleeding pervaginum. She is able to perceive fetal movements. All those things you will elaborate. Then you will move on to history of present pregnancy. Here you will divide the history based on the trimester. First trimester. What do you ask in the first trimester? The mode of conception. How is it relevant? How is it significant? Can anyone say?
Multiple pregnancies can be present in vitro fertilization.
Exactly. Then
Olympic conceptions are common.
Yes.
Infertility. This is spontaneous conception or IVF induced pregnancy.
Yes. With the mode of conception, we can identify her expected date of delivery, or we can accurately say her LMP is good dates or bad dates. Especially with IVF, we know the exact date of embryo transfer. So it is going to be excellent dates. So it is going to be corresponding to the LMP. In other spontaneous, there can be a variation with the gestation age. Then history of hyperemesis. What is hyperemesis? Patient has excess nausea, vomiting in pregnancy that is associated with weight loss with electrolyte imbalance. What is the electrolyte imbalance we are looking here? We are looking for hyponatremia, hyponatremia, yes, metabolic acidosis, which will result in starvation ketoacidosis. How does a patient present? Patient presents with nausea, vomiting, and what are the complications with hyperemesis?
Acidosis.
Patient can have metabolic acidosis. Okay, then patient hypokalemia. Yes, then patient can become delirious, cause of psychosis. Then patient can have subconjunctival hemorrhage. Patient can go into pre-renal failure. All these are complications. Who are the patients who are at high risk for hyperemesis?
Multiple pregnancy.
Very good. Multiple pregnancies. Why? Because there is excess HCG. Then
vesicular mole.
Molar pregnancy. Very good. Then
motion sickness, liver disease, gastritis.
Family history.
Family history, teenage pregnancy, it's all there. Then hypothyroidism, that is also related to hyperemesis. Then we are looking for the history of fever, urinary tract infection. Why? Why fever?
And torch infection.
Torch infection very rarely presents with fever actually. It is actually something like a subclinical infection. So UTI. Fever most common is UTI, URI, and dengue, malaria. All these things presents with fever. Then we are asking history for NT scan. NT scan is a nuchal translucency scan. When is it done?
11 to 13 weeks.
Very good. It is done between 11 to 13 plus 6 weeks. When the CRL, crown rump length, is 45 to 84 millimeter. What are we looking for in the NT scan? It can also be called as a dating scan if the patient has never done a scan before this. So for this, we can confirm pregnancy, confirm it's an intrauterine pregnancy, rule out multiple pregnancy. We can look for viable fetus, then look for any adnexal lesions. What are adnexal lesions we are looking? We are looking for corpus luteal cyst. Then we are looking for the nuchal translucency. If the thickness is more than 2.5 millimeter, the risk for Down syndrome is high. It's not always there is Down syndrome. The risk only increases. Then apart from nuchal translucency, what do we see?
Dipsy.
Nuchal translucency is one of the soft marker. Apart from that, we look for ductus venosus flow, whether there is reversal of A flow. Then we are looking for any tricuspid regurgitation, if tricuspid regurgitation is present or absent. Then we are also looking for nuchal fold thickness. All these are soft markers. The presence of one or more marker will increase the risk. Along with NT scan, what do? We also do dual markers. Not all patients are doing nowadays, but it is randomly accepted to give every patient a dual marker. What are we doing in a dual marker? What are the hormones we are studying?
HCG.
Yes, HCG and
PAPA.
HCG and PAPA. What is PAPA?
Inhibin.
What is PAPA?
Pregnancy associated plasma protein A.
Yes, exactly. What are the triple markers we are seeing?
HCG, inhibin, alpha fetoprotein.
It is not inhibin, it's unconjugated estradiol. So that is the triple marker and this is a dual marker. Dual marker with the NT scan will give a vague idea, around 85-90% if the baby is at high risk for Down syndrome, then Edwards syndrome, then Pato syndrome. Okay. Then you are looking for history of radiation exposure or drug use. You should remember some drugs, at least 5 drugs which are contraindicated in pregnancy. If they ask for anybody to name, if anybody asks you to name, you should be able to name it. Then you're looking for history of bleeding per vaginum. Why?
Missed abortion.
Missed abortion.
Placenta previa abruptio placenta.
Low-lying placenta can present with bleeding per vaginum, and threatened abortion always presents with bleeding per vaginum. And when there is always recurrent bleeding per vaginum in the pregnancy, the baby is at a high risk for intrauterine fetal restriction, IUGR, growth restriction. Okay. Then we are asking about the investigations that are done. What are the investigations that is done in the first trimester?
OGCT.
Blood grouping and typing, hemoglobin, platelet count, then GCT or OGTT, then serology, virology, HIV, HPSAG, if possible HCV, VDRL, very good, thyroid profile, urine routine, very good. You must know the significance of each of these investigations. Okay, we are looking at second trimester. What is quickening? We are asking about when was the quickening felt. What is quickening?
The first movement felt by the mother, fetal movement.
Yes, the perception of fetal movement for the first time by the mother.
The fetal movements, ma'am.
Very good. Quickening yes, quickening is felt by about 18 to 20 weeks by a primigravida and 2 weeks earlier, that is 16 to 18 weeks by a multigravida. And you're asking history of DT intake. It is supposed to come in the first trimester. Now the recommendation for DT is 2 doses has to be taken. 1 dose at the first antenatal visit and the second dose after 1 month. If the patient has never taken a DT while 10th standard or 12th standard by the government recommendation, she is supposed to take another DT dose in the last month of pregnancy. So you're always supposed to take 2 to 3 doses of DT. Okay. Then history of iron and calcium intake. What is the recommended iron? What is the minimum requirement?
100 milligram of iron plus 500 microgram of folic acid.
Yes, it's actually 60 mg of elemental iron because iron requirement every day is about 30 mg. And what about calcium? What is the significance of calcium? Calcium is given as a supplements. One, it can be given either as 1000 mg tablets or 500 mg 2 tablets. What are the significance you know about calcium? The intake of calcium about 1000 mg that is 1 gram per day, reduces the risk of preeclampsia, IUGR. Then history of GCT or OGTT. Most commonly done in Tamil Nadu is GCT, that is 50 grams glucose challenge test. Irrespective of the meals, the patient comes to the hospital, they give 50 grams glucose and you do random blood sugar, that is blood glucose after 2 hours. You know the normal value. If there is something called OGTT, OGTT is not commonly done. OGTT is not commonly done, but OGTT also you should be able to tell. So you take a fasting sample with the urine sample, you give 75 grams glucose. Then 1 hour later, you take another blood sample with the urine sample, another 1 hour, that is 2 hours, blood sample and urine sample. So 92, 180, 153. Either one presence of GDM. When should GCT be done? Ideally,
at first trimester in 12 to 14 weeks, ma'am. But first visit we can do in second trimester 24 to 26 weeks, third trimester 32 to 34 weeks.
Very good. At the first visit itself, we are supposed to do GCT because we classify the mother as low risk and high risk. All women. Indian race comes under high risk category. Any women more than 30 years of age who was obese, previous history of GDM, previous history of macrosomia baby, previous history of operative vaginal deliveries, all this family history and ethnic race, Indian race, all comes under high risk. So all our patients are supposed to be taking GCT in the first visit. But since these patient presents with vomiting, nausea, we are giving them at later, 12 weeks, 14 weeks. At the earliest, we give a GCT. If the GCT is negative, we repeat at 24 to 28 weeks. And if still negative, then we repeat at 32 weeks. Then you will ask history of anomaly scan being done. What are you looking at anomaly scan? We're looking for the viability of the fetus, the number of fetus again. Then we are looking for placental location. What is the Likert status? Then we are looking for to rule out anomalies, gross anomalies. Then we are looking for the cervical length. Neural tube defects we have first seen NT scan. NT scan is for neural tube defects. Which is the first anomaly which can be picked up by a scan? The anomaly that can be picked at the earliest by 12 weeks scan. What is the anomaly?
Anencephaly.
It is very good. It is an anencephaly. That is the earliest anomaly that can be picked. What is the most common anomalies that are left or that cannot be picked by scans, even by anomaly scan? Musculoskeletal anomalies. Any musculoskeletal anomalies most commonly cannot be picked by scans. All membranous defects, septal defects, which that cannot be picked up by scans. So not all anomalies can be picked. That you should know. Then you should ask history of UTI, bleeding periodism, again fetal edema. What are we actually asking for? We are looking for symptoms of any preeclampsia. If the patient had any history of preeclampsia. We move to the next slide. Okay, in the third trimester, what are we asking for? We are asking whether the patient is able to perceive fetal movements. What is DFMC?
Daily fetal movement count.
How will you ask? How will you counsel the patient? How will you explain it to the patient?
Ma'am, after each meal, they have to count for a certain period in the morning and evening.
Very good. You will ask the mother to count for 1 hour in the morning, 1 hour in the afternoon, 1 hour in the night. The patient should have at least 3 kick counts. A total should come to around 9 to 10. This is DFMC. Or there is something called Cardeff's kick count. What is Cardeff's kick count? You will ask the mother to do the count for 12 hours continuously. That should come to around 10. That is, if she starts by morning 8, she should stop by night 8. That is Cardeff's kick count. What does it show? What does the DFMC show?
Fetal movement, fetal viability.
Very good. It shows the fetal viability and the fetal status. Then we are looking for growth scan. What are we looking in the growth scan? We are looking for again for a viable fetus, Likert, placental location, cervical length. Then to look for any new anomalies. Female length, everything comes in biophysical profile. History of bleeding per vaginum, and you're looking for asking history of bleeding per vaginum, pain, abdomen, leaking PV, again all symptoms of preeclampsia. Then you move on to menstrual history. Several places they start with obstetric history, then move on to menstrual and marital history. Some places they start with menstrual history, then marital and obstetric history. So let's start with menstrual history. You'll ask history, age of menarche, menstrual cycle. You'll ask whether the cycle is regular or irregular. How is it significant?
In calculation of ED.
How do you calculate the gestation age? Sorry, the EDD.
9 months plus 7 days.
That is called necklace rule. This necklace rule applies only in case of a regular cycle. If the patient has 28 to 30 days cycle for the previous 3 cycles, this rule applies. If the cycle is shorter, what will you do?
We will reduce the days according to the cycle duration.
And the cycles are longer, you will add the days. So what is called excellent dates?
She has regular cycles for past 3 months, and she had not taken any oral contraceptive pills for past 3 months, and she knows LMP.
Very good. Then also you should add ultrasound where she has done an ultrasound within 24 weeks, which is corresponding to the gestation age. That is excellent dates. So what is a good date? Patient does not know her LMP. Patient might have taken her OCPs, but patient has 2 scans done within 24 weeks, which are corresponding to the gestation age, and that shows linear growth of the baby. So what is poor date? Patient doesn't know her LMP, no scan findings. That is called poor date. So then we'll move on to marital history. She is married for how long, we'll ask. Why is it significant? It is related to
History of infertility treatment.
history of infertility treatment. Okay, then consanguinity. How will you grade consanguinity? First degree.
First degree, second degree, third degree. First degree siblings, second degree maternal uncle, third degree.
Their siblings, their kids. Yes. How is consanguinity related? It is related with the carrier of some diseases. Some diseases runs in families. So 2 carriers marry, so they'll result in actual diseased baby. That's how consanguinity. Then contraceptive history. Why is contraceptive history important? What is the importance of contraceptive history? Do you have any
oral
idea?
contraceptive pills taken, we can calculate LMP. It will affect the LMP date.
Okay, good. Then you're looking for the obstetric history. Obstetric score. I hope you know about gravida, para, live, abortion, ectopic, GPLAE. Okay. Then we are asking about the age of the previous child. Age of the child is significant how it is related to the inter-delivery interval. So that will give an idea about the anemic status of the mother or how is the next mode of treatment. Mode of delivery. Then mode of delivery is previous cesarean or previous operative will give an idea about the mode of delivery now. And indication in case of previous operative delivery and sex of the baby. Birth weight, status of the baby at the present. What is the status? Whether the baby is alive and healthy now or the baby is sick with some anomalies. Then you'll also ask about when was she discharged from the hospital, if there was any blood transfusion. Then if the patient was given any high dose antibiotics, all this you can collect it from her. In case if there is a history of abortion, you'll ask if it is a spontaneous or induced. And if it is complete or incomplete. What is the significance of complete or incomplete? In case of an incomplete abortion, patient might have had history of blood transfusion. She might have undergone a DNC and patient might have resulted in endometritis. All these histories you can collect. Then gestation age. At what period of age she had an abortion? Why is it significant?
It will affect current pregnancy, also any congenital chromosomal anomalies, genetic disorders.
Gestation age. If the patient had an abortion in the first trimester, that is before 14 weeks, it is not much to do with this pregnancy. If the patient had an abortion in the second trimester, the patient might have cervical insufficiency. There is something called cervical incompetence. So the patient again might have a cervical incompetence. So we should be able to track her cervical length and we might need a cervical stitch. And you must ask history of post-abortal complications. What are the post-abortal complications? History of excess bleeding, history of blood transfusion, long-term hospital stay, high-dose antibiotic usage. All this you should ask. Okay, yeah. History of retained products. All this presents with excess bleeding. So then you'll ask about inter-pregnancy interval, that is again related with anemic status of the mother. Then past history. What are we eliciting in the past history? Like any other history, medicine, surgery, we'll ask medical history, previous history of diabetes, hypertension, tuberculosis, bronchial asthma, or any other diseases. Surgical history. How is it related? How is medical history related? If the patient is having hypertension, patient was on some medicines like AC inhibitors, ARVs, which are contraindicated in pregnancy. Then patient might have some, baby might have some anomalies. If the patient was on warfarin, patient has been changed to heparin. Yes, very good. Warfarin. What does a baby present with? Fetal?
Hydantoin syndrome.
Very good. Okay, surgical history. Surgical history. What are the surgical history? Why are we eliciting surgical history?
Past gynecological history, amputation of the cervix, it will affect the cervical incompetence, it will cause.
Very good.
Podization,
Very good.
myomectomy, it will all cause.
It will result in cervical incompetency, again second trimester loss. Then the patient, in case the patient had recurrent surgeries, it might result in adhesions and patient might have preterm labor. Then history of drug allergy. Then history of blood transfusion. Can you move to the next slide? Family history. Again, like anything, hypertension, diabetes, multiple pregnancy, unexplained fetal deaths, or unexplained adult loss. We are eliciting that. Then personal history. We are asking her about the diet, whether she's a vegetarian or a non-vegetarian, to know her status. Then appetite, sleep, bowel and bladder habits, if she has any addictions. Then dietary history. Dietary history is very important in some parts. I don't know whether everybody is taking the dietary history. So in dietary history, we are supposed to actually calculate the kilocalories. Do you know how to calculate the kilocalories? Are you taking the history? Dietary history?
24-hour recall method.
24-hour recall. Are you taking the history and presenting the exam? Okay, no. Okay, then no. In case if you're taking the history means, like in pediatrics only, 1 idli, 1 dosa, 1 chapati is 50 kilocalories. 1 normal cup rice is 100 kilocalories. Then most commonly used food items, you need to calculate the diet. Minimum requirement should be 1800 kilocalories. Then further, it will improve with the patient's pre-pregnancy BMI. So we move on to examination. General physical examination, we are looking for the build of the mother. Why are we looking at the build?
And we can calculate the weight gain during pregnancy.
Yes, very good. Build will state the nutrition status of the mother. Again, with the pre-pregnancy BMI, we can advise her to take the calories. With the pregnancy, how much should be extra calories should be taken in pregnancy?
350, ma'am.
350, very good. With the lactation, 600 kilocalories. Very good. So then pallor. I hope you know the places where we are looking for pallor. Then icterus, cyanosis, pedal edema. How will you grade pedal edema?
Based on the level of edema, up to ankles.
Yes, grade 1 is up to ankle, grade 2 is up to knee, grade 3 involves the thigh or 2 separate regions, grade 4 is generalized anasarca. Pedal edema classification is very important. Then we are looking for any lymphadenopathy. You're looking at the vitals, pulse rate, respiratory rate, then blood pressure, temperature. How do you measure the blood pressure? You always ask the patient to lie in a semi-recumbent position or in the left lateral position, and you place the cuff in the right arm and the apparatus at the level of heart, and the cuff should encircle 2/3 of the arm's length. Then we rise, first to use a palpatory method, then use the auscultatory method. Always use sphygmomanometer. Okay. Then you're looking at the breast. What are we looking for in the breast? You're looking for any lump?
Inverted
nipple? Inverted nipple. Very good.
Milky discharge, ma'am.
Milky discharge. Actually, we are not supposed to get
insufficiency.
Yes, we are not supposed to get in pregnancy. In case if we get, then it indicates placenta insufficiency or ongoing labor. Then
any lump?
Yeah, we are looking for any lump. Okay. Thyroid, you are looking for any thyromegaly, organomegaly. Then spine. Why are we looking at the spine?
Kyphoscoliosis, any abnormalities will it affect that mode of delivery, normal
Yes.
vaginal delivery.
If there is a kyphosis or there is scoliosis, it will result with contracted pelvis. So it might result in variation in the mode of delivery. Then respiratory system, cardiovascular system, central nervous system. Then also you should include abdomen, per abdomen examination where you will tell about the loin and groin, whether there is any hernia, any scars. We'll go to obstetric examination. What is the first to do? We look at inspection. How will you describe? Uterus is enlarged longitudinally or transversely, or there is oblique enlargement. Abdomen distended, அப்படி சொல்லக்கூடாது. It's a longitudinal enlargement அப்படிதான் சொல்லணும். Abdomen distendedனா ascites சொல்ற மாதிரி இருக்கும் அது. Then you will say about the linea nigra, stria gravidarum, and you will state about umbilicus. Very good. Whether it's stretched, flattened, or everted. And if there is any presence of scars, keloid, very good. Sinuses, then dilated veins. Then the palpation, what do? You are looking for the fundal grip. Yes, hernial orifices on before we finished. What are we looking on the fundal grip? We are looking either for a how do you present a breech at the fundal grip? How does a breech? How do you describe a breech? Buttocks in the fundal grip. It's a
soft, non-palatable.
Very good. Soft, large, broad, non-palatable mass, which is palpable in the fundus, most likely buttocks. You will always say most likely. Then, if it is a smooth, hard, globular, and palatable mass, which is felt at the fundus, that is most likely head. With that, you can identify the presentation. Then, lateral grip. With the lateral grip, you are looking for smooth, hard, resistant feel on one side, which corresponds to spine, and irregular knob-like structures, which corresponds to limb buds. Good. First pelvic grip. What does the first pelvic grip help you to do? It will help you to identify the presenting part. Then, second pelvic grip will help you to identify whether it is
engagement occurred or not. Which part is engaged?
Very good. Then you will tell about the liker status, whether it is adequate liker. Then you will auscultate. You are auscultating for the fetal heart rate along the fetal spine. If you are auscultating and you're getting two fetal heart sounds between 10 centimeters apart with a variation of 10 beats per minute, that indicates again multiple. You should always present this multiple fetal parts palpable, 3 fetal poles palpable, 2 buttocks and 1 head palpable, or 2 head and 1 buttocks palpable. All these corresponds to multiple fetus. Then measurements. What are the measurements we have left out? We have left out the symphysiofundal height and the abdomen girth. How is symphysiofundal height important?
Week of gestation.
Yeah, with the symphysiofundal height, you can identify the gestation age by multiplying by 8 and dividing by 7. So just symphysiofundal height into 8 by 7 will give you the gestation age. How will you calculate the weight? The fundal height in centimeter minus 11 in case of an engaged head, or 12 in case of a non-engaged head, into 155 will give you the weight, approximate weight, plus or minus 300 grams. Then you'll go on to diagnosis. This is the most important part, because when there are some 20-30 kids writing the exam, first 10 kids will present. The next onwards, they'll get very bored. So they'll ask you to directly say the diagnosis. How will you present the diagnosis? So for example, you can say 24-year-old, gravida 1, gravida 2, gravida 1, live 0, presents with 8 months of amenorrhea, with 24 weeks size of uterus, with longitudinal lie, with cephalic presentation, with anemia complicating pregnancy. They may give the pelvic examination findings or they may not give. Both is fine. Okay, the diagnosis should be very complete. It should include the age, it should include the obstetric score, it should include the period of gestation, then it should include the lie, presentation, and associated complications. Then we're looking at the management plan. They'll ask you if the patient has anemia, they'll ask you, how will you classify anemia? How do you define anemia?
There is a decrease in oxygen carrying capacity of the blood.
Very good. How will you define? When the hemoglobin content is less than 11 grams or the hematocrit is less than 0.33. That is WHO's classification. Or you can say less than 11 in first and third trimester and less than 10.5 in second trimester. That is also WHO or mostly CDC criteria. Then by classification, how will you classify ICMR classification? Many of you are writing it. The ICMR classification, mild, moderate, severe. First they will ask about this classification. Then they'll ask about types of anemia, iron deficiency anemia. How will you classify anemia? What are the types, You can classify as microcytic, macrocytic, and
Normocytic.
normocytic or even dimorphic. Most commonly found is iron deficiency anemia. So what they ask is, what is the iron requirement? 4 to 6 mg per day is the iron requirement. How will you diagnose? What are the other blood tests you do to diagnose anemia? What is the one blood test we are needed? Yes, very good. Peripheral smear.
Serum.
Very good. Peripheral smear. That is most needed. One blood investigation that is most needed is peripheral smear. What other you can do? Yes, you can do serum ferritin, serum iron. That is all there. Then iron indices you can do. Yes, very good. Then you are supposed to do
Serum ferritin, serum total iron binding capacity.
Then you'll do stool examination and urine examination. What are we looking for in the stool?
Stova.
Hookworm infestation, worm infestation, and urine for occult blood again with parasites. Then you can proceed with sputum examination. Chest X-ray. What are we looking for in sputum and chest X-ray?
TB.
Very good. Tuberculosis. Most commonly associated tuberculosis. How will you manage anemia?
In last trimester administration.
Depending upon the gestational age and severity.
Yes. Anemia management always depends upon two things. One is the anemic level. Second is the gestation age. If the patient is in the last trimester of pregnancy, that is around somewhere around 36, 37 weeks, there is no use of oral therapy or parenteral therapy, because oral therapy and parenteral therapy will improve the iron status only by 3 weeks post treatment. So you are supposed to treat with blood transfusion. Patient presents with severe anemia, that is less than 7 grams per TL, in any trimester, any part of gestation, you are always supposed to treat with blood transfusion. Patient presents with moderate anemia in the last trimester, then last trimester around 36 weeks, you are again supposed to treat with blood transfusion. So it always depends upon the gestation age, anemic status. Then what is the iron therapy which is most commonly given? Oral iron therapy, which is the oral iron we most commonly give?
Iron sucrose.
Iron sucrose.
No, oral iron.
Ferrous sulfate.
Ferrous sulfate is most commonly given, but it's not tolerated. Best given is
Fumarate.
ferrous ascorbate. Ferrous ascorbate is the best oral iron therapy. How will you calculate iron requirement for parenteral iron therapy?
Manufacturer's formula based on hemoglobin
4.4 into weight of the person in kg into hemoglobin deficit.
2.4 into weight.
4.4 0.3. 0.3 into weight into hemoglobin deficit plus 500 in case of a chronic loss or plus 1000 in case of an acute loss. That is iron requirement. Then how much is iron sucrose you give? You give about 100 to 200 mg per day. Alternate days, around 600 mg per week. That is the iron infusion you can give. What are the complications with the parenteral iron?
Pigmentation.
Very good. That is with IM, not with IV. Very good. Anaphylaxis.
Thrombophlebitis.
Anaphylaxis allergy is the most common complication with parenteral iron. Okay. Along with parenteral iron, we are supposed to give them folic acid, vitamin B12. In whom and all we give folic acid continuously in pregnancy? Folic acid is ideally given till 12 weeks of pregnancy. For some people, we give folic acid the entire pregnancy. Very good. Patient who's on antiepileptic drugs. Previous history of neural tube defects baby. Then patient is obese. Then patient has megaloblastic anemia. Then patient is hypothyroid. All these patients will receive folic acid throughout pregnancy. What is the recommended dose for folic acid?
500 micrograms.
The recommended doses, minimum dose is 400 micrograms. We are giving 500 micrograms because it is the only available drug in India. 400 micrograms is not available. And patient who had history of neural tube defects, babies, are supposed to be taking 5 milligrams. So these are the questions you'll ask in anemia. Then we'll move on to previous cesarean pregnancy. Shall we move on to previous cesarean pregnancy?
Yes, ma'am.
How will you classify the urgency of pregnancy? They might ask. Category 1, Category 2, Category 3, and Category 4. Do you know this? Classification of urgency of a cesarean section. Category 1 is you are supposed to do within 15 to 30 minutes. That we need to do a cesarean section within 15 to 30 minutes of diagnosing. In case of a cord prolapse, in case of a fetal distress, then in case of abruptio placenta, then in case of rupture uterus. Very good. Then category 2, then category 3. Category 2 and category 3 overlaps within 75 minutes of identifying that problem. Then category 4 is elective. So 1, 2, 3, 4, this you should know. What is the most common indication for cesarean section? What are the indications you know?
Cephalopelvic disproportion.
Cephalopelvic disproportion. This can be classified as major CPD, minor CPD. Major CPD will always be stated as contracted pelvis. So first indication is contracted pelvis. Second is
Placenta previa.
Yes, placenta previa. What placenta previa?
Placenta.
Abruptio placenta. Okay. What placenta previa we do cesarean section?
Complete placenta previa.
Complete placenta previa.
3 and 4.
And 2B also we are doing cesarean section. Why? 2B is more dangerous.
Posterior will obstruct the fetal descent.
Very good. Yes, posterior placenta will obstruct the descent of the fetus. Also, it will worsen the postpartum hemorrhage. So that is more dangerous. That is called a dangerous. What is the sign? What is the sign you elicit in placenta previa and type 2B? When the fetal part is present, fetal part is pushed into the pelvis.
Reduced heart rate.
Yes, this is called Schilling sign. Stalworthy sign. Very good. Sorry, Stalworthy sign. Then what is the antibiotic that you give in case of cesarean section? Antibiotic of choice? Any third generation cephalosporin you can say.
Ceftriaxone.
Third generation cephalosporin. And what is postpartum hemorrhage?
Bleeding
of 500 ml of after normal vaginal delivery or 1000 ml after cesarean section.
Very good. Postpartum hemorrhage. What are the causes? Can you say some causes?
Tonic PPH, traumatic PPH, tissue retained placental tissue, bleeding disorders.
How will you manage first? How will you manage a postpartum hemorrhage? First, you will secure 2 large bore cannulas, green venflons, 2 large bore cannulas, and you take blood to look for hemoglobin status, hematocrit status. Then acid-based analysis, acid blood class analysis. Then
Uterotonics.
Oxytocin.
You try to replace it with blood. Start blood, then you start giving uterotonics. You'll start with oxytocin. How much oxytocin can you give?
10 units. Take oxytocin.
You'll increase to 20-30 units also you can give. Then you can add with methogen, misoprostol. There is no actual protocol. No hospital has a particular protocol. So what is the maximum dosage of misoprostol you can use?
800.
800 in case of a, actually 600 in case of a prophylactic and 1000 in case of therapeutic. That is the dosage of misoprostol. Misoprostol will take at least 10 minutes to act. Then you can give methogen. Methogen, what and all condition is contraindicated for methogen?
Heart disease.
Preeclampsia. Preeclampsia.
Hypertension, very good. Hypertensive disorders, that is contraindicated. Then what are the indications, you know? Carboprost.
Carboprost.
Where is it contraindicated?
Asthma.
Very good. Bronchial asthma. Then what other you can do if this is about medical management? This medical management fails. What other you can do for postpartum hemorrhage?
Uterine
Compression. Yes. Then
Compression.
Mechanical.
Aortic compression.
tamponade. First word that should come is Foley tamponade. You should put a Foley tamponade and you should inflate the bulb to about 120 ml. Then you can wait. You can. Meanwhile, you should give her blood transfusion. Or yes, you can use a suction cannula also. That is also another surgical management. All this fails. Then what do you do?
Uterine compression.
Uterine artery embolization.
Yes, stepwise devascularization. Uterine artery embolization you can do, or stepwise devascularization. That is, you can start with uterine artery, then you can yes, or you can proceed with hysterectomy. PPH is very important. Anywhere they can start and they'll end up with PPH. They can ask a lot of questions in PPH. Okay, tomorrow what shall we discuss? I don't know how we have discussed your medicine and surgery. So I tried my best to discuss this one. So what do you want to discuss tomorrow? Any ideas you have?
Gestational diabetes complicating pregnancy.
You want to discuss today or tomorrow?
Tomorrow, ma'am.
Today.
Okay then. You want to discuss like this or you want me to put a PPT and then talk?
Like this isn't okay, ma'am.
This is okay. All these are basic questions because most of the professors will be asking only basic questions. Once you have finished with the basic questions, they'll move up. But always when you flunk at a bigger question or a high funda question, it is okay. But you flunk at a basic question, they become very annoyed. Want a PPT? Okay. Okay, tomorrow we'll discuss about GDM. Then what else you want? AUB. Okay. Tomorrow we'll discuss about the gynae cases. Gynae cases most commonly given as abnormal uterine bleeding, then prolapse, then fibroid. This AUB itself will come fibroid. Then infertility they don't give a case, right? I don't think they're giving a case in infertility. Okay, what are the gynae cases we have? AUB, which will include fibroid, then which will include pelvic organ prolapse. Malignancies they can give CSFX.
Leukorrhea.
Very good. Postmenopausal bleeding they'll give, yes. Vaginal discharge, leukorrhea they can give. Okay. We'll vaguely discuss all that. I'll try maximum to put a PPT. But I'm used to this type of teaching. Okay, anyway, go read.
Thank you so much for this amazing interactive session. Tomorrow, see you all with another case presentation at 6:30 p.m. Note the timing, please. 6:30 p.m. Thanks for joining. See you all in tomorrow's session. Thank you so much, ma'am. Thank you everyone for joining.